Hello, good evening once again, and welcome to today's lecture. In today's lecture, we are going to talk about antihypertensives. And if this is the first time you are watching this channel, I will encourage you to watch the previous videos where we discussed in detail the general classification of antihypertensives. And in this one, we are going to look at the angiotensin blockers. Specifically, we are going to talk about the angiotensin converting enzyme inhibitors, the angiotensin 2 receptor blockers, and also the direct renin blockers. So, if you watched the previous video, you realize that we described the general mechanism by which the renin angiotensin aldosterone system works to regulate the blood pressure. So basically, the first drug we are going to talk about, or the first class of drug we are going to talk about, are the ACE inhibitors, or the angiotensin converting enzyme inhibitors. And examples of these drugs are the lisinopril, the captopril, the enalapril, and all those drugs which ends with the pril. And basically, when we pick how they work, the mechanism of action of these angiotensin converting enzyme inhibitors, you realize that they block the conversion of angiotensin 1 to angiotensin 2. And that's all. Basically, this is how angiotensin converting enzyme inhibitors work to help reduce blood pressure, or in a patient with hypertension. So they block the conversion of angiotensin 1 to angiotensin 2. They do so by inhibiting the conversion or the converting enzyme, which is the peptidyl dipeptidase, and also the angiotensin converting enzyme, and prevent it from converting angiotensin 1 to angiotensin 2. And by so doing, they also decrease the breakdown of bradykinin, which is also a potent vasodilator. And so once we are not going to get angiotensin 2, all the effects of angiotensin 2, which we saw in the previous video, basically causing a positive inotropic and also a positive chronotropic effect on the heart through the sympathetic activity, will be abolished. Also, the effect whereby angiotensin 2 will lead to tubular reabsorption of sodium and also chloride, as well as water, and the excretion of potassium will also be abolished. And so once we are not getting reabsorption of water and sodium, cardiac output is going to drop, or is going to fall. And once cardiac output falls, you remember we said cardiac output is the one which determines the systolic blood pressure. So once cardiac output is falling, then the systolic blood pressure will also come down. Also, once we block angiotensin converting enzyme from converting angiotensin 1 to angiotensin 2, we are going to also prevent effects such as the cortex of the kidneys releasing aldosterone. Also, we are going to prevent the arterial vasoconstriction, and we're also going to inhibit the release of antidiuretic hormone from the posterior pituitary gland, which will act on the collecting ducts to prevent the reabsorption of water back into circulation. By so doing, we reduce the circulatory volume, and cardiac output will fall. So basically, this is the mechanism by which angiotensin converting enzyme works. So when we pick a drug like lisinopril, it is almost I think the major drug which is not metabolized by the liver, and is eliminated unchanged in urine. And it is also important to note that lisinopril is hydrophilic, and it has a long half-life of about 11 to 12 hours. When we pick captopril was the first ACE inhibitor to be released on the market, and since it was the first, it has a lot of side effects, and it requires multiple dosing in a day, and so a patient may have to take about 2 to 3 times of this particular drug in a day. And it's also associated with taste disturbances, and this taste disturbance is particularly due to its sulfonyl moiety present in it. It causes a change in the taste buds, and also there's taste disturbances. So basically, this is the mechanism of ACE inhibitors. So the pharmacologic or the pharmacological effect of the ACE inhibitors, as we've seen, is that they are going to reduce the total peripheral resistance and also the mean arterial blood pressure, and they do this without causing any increase in cardiac output, or sometimes there is no effect on the cardiac output at all. They are also associated with no reflex sympathetic activity, and because of this, they can also be used safely in patients with ischemic heart diseases. Clinically, we use ACE inhibitors to treat mild to moderate hypertension, and also in congestive cardiac failure patients, we give ACE inhibitors to them. Now, what are some of the adverse effects of ACE inhibitors? We know that on the central nervous system, it causes headache, dizziness, and fatigue. Especially when you are using the enalapril, and also on the cardiovascular system, it may also cause severe hypotension, since it is preventing the reabsorption of water back into circulation, and this is usually severe in patients who are already hypovolemic. And also on the renal system, we may also have acute renal failure and also hyperkalemia. And as we saw in the previous slide, because the ACE inhibitor is going to promote the reabsorption of potassium, it may lead to hyperkalemia in these patients, as well as proteinuria in these patients, and also angioedema, whereby they are going to have swelling of the face and other parts of the body. Respiratory system adverse effects are basically dry cough, as we've seen. I mentioned it earlier on. Also associated with enalapril as well, and also wheezing. In the blood, we are going to have neutropenia, skin rashes, and also, as we saw with captopril, we are going to have altered taste. It is important to note that another example of ACE inhibitor, which is perindopril, is one of the long-acting ACE inhibitors, and it has a half-life of between 16 to 20 hours. And in contrast with the captopril and another one known as the ramipril, they have a very short half-lives of around 2 hours, and this is why we may have to give multiple doses of captopril to a patient in a day. And looking at the contraindications of ACE inhibitors, I've summarized it into PARK. That's PARK. So the first one that should come to your mind is pregnancy and lactation. So we may not give we will not give ACE inhibitors to the pregnant women, because in pregnancy it is associated, when you give ACE inhibitors, it is usually associated with oligohydramnios, and that means it leads to decrease in the amniotic fluid which the baby lies or lives in it. It also leads to stillbirth in some instances, and also neonatal renal failures. And this class of antihypertensive should be avoided in pregnancy as much as possible. And we also have it associated with allergies and also angioedema and also renal impairment, basically because of its effects on the hyperkalemia and also its effect on proteinuria. Then we can also see it in, as I've talked about, a patient with hyperkalemia of more than 5.5 millimole per liter. You may not want to give ACE inhibitor to the patient, since the patient already has a high potassium level. If you give an ACE inhibitor, it's going to promote the reabsorption of potassium in the renal tubules, and this will cause, or this will lead to negative consequences on the heart. So basically, I've grouped all the ACE inhibitors in one box, and as you can see, we have the drugs: the captopril, enalapril, lisinopril, perindopril, ramipril, and also the transdolapro. So these are their indications. You can go through them later on. For want of time, we cannot look at all of them one by one. You can go through them and see what they do. But an important thing that I want to draw our attention to is the contraindications to these drugs. Now, it is also very important that we should not give an ACE inhibitor together with an angiotensin 2 receptor blocker. So it's very, very important. Yeah. Now, the next one we are going to look at is the angiotensin 2 receptor blockers, commonly known as the ARBs. And common examples of these ARBs are the angiotensin, are the irbesartan, losartan, olmesartan, valsartan, irbesartan, and candesartan. So I made a mnemonic. I use this word. I hope it's appropriate. I love candies. So the I stands for irbesartan, the L stands for losartan, O stands for olmesartan, valsartan for the V, and also irbesartan. Then the candies will stand for candesartan. So how does angiotensin 2 receptor blockers work? Basically, as we've seen with angiotensin 1, in angiotensin 2 receptor blockers, we are going to find out that, so as you can see where the stars are placed, these are the points at which angiotensin 2 are going to work. And so when we give angiotensin 2 receptors, they are going to block the effect of these angiotensin 2, and so the sympathetic effect of angiotensin 2 is going to be inhibited. Sympathetic effect of angiotensin 2 on the renal tubules will also be inhibited, and so we are not going to have sodium chloride and water reabsorption back into circulation. Rather, we are going to have sodium chloride and water being excreted, whilst potassium will be reabsorbed back into circulation. Also, its effect on the kidneys, which is the release of aldosterone, is also going to be inhibited, and also is going to also prevent the angiotensin 2 receptor blocker is going to prevent the systemic vasoconstriction, as well as the effect of antidiuretic hormone is also going to be prevented. And so we are not going to have fluid or water being reabsorbed back into circulation, but rather they are all going to be excreted. So basically, this is the simple way by which angiotensin 2 receptor blockers perform their work. Now, the pharmacological effect of angiotensin 2 receptor blockers, like they decrease the total peripheral resistance, that's the afterload, and also venous returns. And so the amount of blood which is going back to the heart reduces, and once venous returns reduces, cardiac output will also reduce. And as we learned earlier on, cardiac output determines the systolic blood pressure, and so once cardiac output reduces, blood pressure is going to come down. It also reduces blood pressure independently of the status of the renin angiotensin system, and so the plasma renin activity increases due to removal of angiotensin 2. In this situation, we have nothing to do with angiotensin 1. You understand? And so, even though we are blocking angiotensin 2 receptors, we are still going to have the production of what? Of renin. And so it's going to pile up, inside the system. Since there will be no negative feedback mechanism to, go to it to prevent the kidneys or the juxtaglomerular apparatus from producing the renin. So clinically, we use the angiotensin receptor blockers, the ARBs, to treat mild to moderate hypertension, and it's also effective in the management of diabetic nephropathy. It is useful because it helps in the it helps in preventing disease progression by reducing the levels of proteinuria in the system, and so the disease diabetes may not progress, or the diabetic nephropathy may not progress. So basically they reduce the levels of proteinuria, and so they prevent disease progression. Now, like I said earlier on, angiotensin 2 receptor blockers should never be given together with ACE inhibitors. It's very, very important to note this point. Now, one quick point I want to draw our attention to before we move on to the direct renin inhibitors is that ACE inhibitors, as we talked about earlier on, increases the risk of renal failure. This occurs particularly when it is taken in combination with both NSAIDs and diuretics. And it also, do not, an important point to note over here, they do not increase the breakdown of bradykinin. Rather, they decrease the breakdown of bradykinin, and so we find ACE inhibitors being used as the first line of treatment in heart failures. It's very, very important for us to note this. And also, as we saw that the side effect of some of these ACE inhibitors, includes dry cough. Usually, when this happens, it usually worries the patient, and so you may want to switch these patients from the ACE inhibitors to another drug. And the best drug usually to switch these patients on are the ARBs, or the angiotensin 2 receptor blockers, or the SATANs. So it's very, very important. And also another point on the potassium levels. We realize that ACE inhibitors and angiotensin 2 receptor blockers can cause hyperkalemia, but they do not have any effect on the sodium levels and may cause transient increase in BUN as well as the creatinine, but they do not cause renal failure. It's a very important point I want us to note before we move on. So the next class of drug I want us to look at is the direct renin inhibitor. And the direct renin inhibitor, as we saw earlier on, their mechanism of action is that they inhibit the binding of renin to angiotensinogen, as we saw. And so this drug binds to the active site of renin, and it inhibits the binding of renin with angiotensinogen, which is a rate determining step of the angiotensin, or the renin angiotensin aldosterone system or cascade. So once this step is blocked, then we are not going to have angiotensin 1, we are not going to have angiotensin 2 for you to give us all the effects of vasoconstriction, for it to give us all the effects that it has. So consequently, this is what happens once you block the the binding or the interaction of angiotensinogen with renin. Then all the cascade, or all the steps which are left, will also be prevented. So the common drug that we have under direct renin inhibitor is the aliskiren. Very, very important drug to use. and we use it basically for the treatment of hypertension. And it is important for us to note that it causes elevation in the serum potassium as well as creatinine level, and should not be combined with ACE inhibitor or angiotensin 2 receptor blocker in patients with diabetes, purposely because of the renal problems associated with it. So if the patient's glomerular filtration rate is below 60 millimeters per minute, you may not want to give this drug to the patient. Now in this slide we have all the angiotensin receptor blockers brought together, and when they are indicated, also their side effects, as well as the cautions we need to take before we give these drugs, and their contraindications. So like we said earlier on, most or all of these drugs ends with a sartan, so we call them the sartans. So we have the candesartan, iprosartan, irbesartan, losartan, valsartan. They are very, very important, and their indications are over here. For want of time, we may not be able to go through all of them one by one, but these are basically how they are used for the treatment of hypertension. If a patient cannot tolerate ACE inhibitors, you may want to switch this patient to a angiotensin receptor blockers, and also in post myocardial infarction patients. And the possible side effects, like with all antihypertensives, you may have hypotension, you may have dizziness and headaches, and also sometimes you may have hyperkalemia. Very, very important for us to know. So these are basically the things which are found over here, and the contraindications, as we saw in ACE inhibitors, it is also contraindicated to give ARBs in pregnancy as well. Very, very important for us to note. So to bring our discussion to an end, I organized some few multiple choice questions for us to discuss and see how we understood this topic on ACE inhibitors as well as ARBs. So the first question, let's see, I'll give you some few minutes, just look through it and see if you can get the answer. Your patient says he has lost tastes for food. Which of the following ACE inhibitors is associated with taste disturbances due to its sulfurhydryl moiety? I think we discussed this before. So the most important thing that you have to look for here is the loss of taste, and as we said, captopril is the type of ACE inhibitor which is associated with loss of taste or taste disturbances. In the second question, which of the following ACE inhibitors has a long-term effect? So if you remember, we talked about perindopril having a half-life between 16 and 20 hours, if you remember, and we said ramipril as well as captopril rather are having a very short half-life of about 2 hours. Then which of the following about ACE inhibitors are false? So let's look through. Which do you think is false? Does it increase risk of renal failure? Does it break down bradykinin? And also, is it contraindicated in heart failure? So we know that it does not break down bradykinin, and we also know that it is not contraindicated in heart failure. It is usually the first line of treatment in heart failure, and so the false answer is it increases the risk of renal failure. Okay, so the best answer here is as we've seen already. So ACE inhibitors increase the risk of renal failure, particularly as we've seen if taken with both NSAIDs and diuretics. However, they do not increase the breakdown of bradykinin, rather they decrease it, as we've said earlier on, and they are usually used as a first line of treatment in heart failure. So the B and C will be the wrong answer, or will be false. The next question: which of the following ACE inhibitors is not metabolized in the liver and is eliminated unchanged in the urine? If you remember, we talked about this in the lecture. So what will your answer be? I think the answer is going to be lisinopril, because we said it is not metabolized in the liver, and it has a half-life of about 12 hours. Then patients who experience persistent dry cough are switched to which of the following antihypertensives? I hope this one is just straightforward. We just talked about it. So will you give your patient beta blockers if the patient complains of dry cough, persistent dry cough, or calcium channel blockers, or angiotensin receptor blockers? I think the answer is angiotensin receptor blockers. The next one, ACE inhibitors are not effective in the treatment of diabetic nephropathy. True or false? I think this one, we know the answer already. As we said, ACE inhibitors are very effective in the treatment of diabetic nephropathy because they reduce the levels of proteinuria, and also they slow down the disease progression. And so the answer is false. Then the last question, which laboratory value should a doctor pay close attention to when a patient is on ACE inhibitor or on angiotensin 2 receptor blocker? So we talked about a lot of things. We talked about potassium, we talked about the blood urea nitrogen, we also talked about sodium levels. So which one do you think you should pay much attention to if your patient is receiving ACE inhibitor? And if you remember, we talked about potassium much. So potassium should be given keen attention, because ACE inhibitors and angiotensin 2 receptor blockers can cause hyperkalemia, and as we said, they have no effect on sodium, and they may also cause transient increase in blood urea nitrogen and creatinine, but they do not cause any renal failure. So the answer is A over here. So potassium, as ACE inhibitors and ARBs can cause hyperkalemia. So this is the end of today's lecture on ACE inhibitors, angiotensin 2 receptor blockers, and also direct renin blockers. Thank you very much for your time. Please do not forget to subscribe. Thank you.